Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along and they will be addressed. I'm honored to introduce our mentor for today, Dr. Chima, who is going to be closing out our gastroenterology month this month of April 2024, where we're going to be closing off gastroenterology with hepatology, which is basically a study of the liver and its diseases and functions. We'll start off with anatomy and physiology and go into various case studies. Thank you so much, Dr. Chima.
Very good morning, everyone. Thank you for joining us today on this Saturday morning. It's very cloudy in Maryland. I don't know what's the weather at your end, but welcome, everyone. So as Minahal mentioned, today we talk about liver anatomy physiology, hepatology, and the liver disorders. So let's go over briefly, pretty quick, about anatomy and physiology. So basically, liver is the second largest organ after the skin in our human body. And it's weighing about 1,500 grams. It lies under the diaphragm in the right upper abdominal area and the mid-abdomen and extend to the left upper abdomen. So I will show you the pictures as well so you have a better idea. So human abdomen is divided into quadrants and regions. So there are 4 quadrants: right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. And there are 9 abdominopelvic regions as well, you can see in this diagram as well. So the division into 4 quadrants allows the localization of the pain, tenderness, any scars, any lumps, and this is how we can narrow down which organs are lying in which quadrant, and which organs and tissues are involved when patient present with those symptoms. And these quadrants are referred to as I mentioned, left lower quadrant, left upper quadrant, right upper quadrant, and right lower quadrant. And these terms are basically used to identify different organs. And basically, I will just talk about the right upper quadrant where we have liver. It extends from the median plane to the right of the patient and from the umbilical plane to the right rib cage, as you can see in the diagram as well. And from the umbilical, and this is the, excuse me, the organs in this area are the liver, gallbladder with biliary tree, duodenum, the head of the pancreas lies here. There's a right kidney and the adrenal glands, and the hepatic flexure of colon lies in this area. And then we have a left upper quadrant. It extends from the median plane to the left of the patient, and from the umbilical plane to the left rib cage. And the organs over here, the stomach, spleen, there's the left lobe of the liver, then body of the pancreas, left kidney, adrenal gland, there's a splenic flexure of the colon, and there's a part of the transverse colon and descending colon as well. So likewise, there are other organs lying in the left lower quadrant and the right upper quadrant, as in the left lower quadrant as well. So I will not go over those organs. We are focusing on these 2 quadrants where we are going to talk about our liver. So what are the lobes of the liver? So first of all, very important, learn the different lobes: right lobe, left lobe, quadrate lobe, and quadrate lobe. So in the interior view, as you can see in the diagram, we can see the right lobe of the liver and the left lobe of the liver. And on the posterior view, you can see the posterior aspect, you can see the quadrate lobe is located on the inferior surface of the right lobe, and the quadrate lobe is located, can you please move on the next diagram, please? The quadrate lobe is located between the left and right lobes in an anterior and superior location. And from embryological standpoint, the liver grows as a ventral diverticulum of the junction of the foregut and the midgut into the ventral mesogastrium. That is the caudal part of the septum transversum, and the cranial part forms the diaphragm. So this is just briefly, I want to talk about the embryology of the liver. And the same diverticulum forms the gallbladder and bile ducts as well. And there are the different ligaments of the liver also form from this as well. So also you can see in this diagram, there's a gallbladder. It's a separate organ that works closely with the liver and is attached to the bile duct. And the gallbladder stores the bile and it releases the bile back into the ducts whenever needed. So let's go over briefly the ligaments of the liver. So liver has several ligaments attachment that anchor in the right upper quadrant of the abdominal cavity. And these include the coronary ligament, triangular ligament, the largest one is the falciform ligament, the round ligament, hepatogastric ligament, and then the hepatoduodenal ligament, and together with the ligamentum venosum. So there are false ligaments and the true ligaments. The false ligaments are basically mere the folds of the peritoneum. So peritoneum is the lining that lines all the organs of the abdominal cavity. And while the true ligaments are the fibromuscular bands, that is like a ligamentum teres hepatis and the ligamentum venosum. So let's talk about briefly about the falciform ligament. So falciform ligament is the broad and thin fold of the peritoneum, and it's being directed downward and backward, and its apex upward and forward, and it drops down from the hilum of the liver, as you can see in this diagram. So falciform ligament, which divides the liver into the two larger anatomical right lobe and a smaller anatomical left lobe. And it has two layers of peritoneum, and this falciform ligament attaches the anterosuperior surface of the liver to the anterior abdominal wall and the diaphragm. And the free edge of the falciform ligament contains the ligamentum teres hepatis, also called the round ligament of the liver. I know I'm talking about too much about the ligament. Just briefly go over, and these are the basically the obliterated umbilical vein, and which is attached to the inferior surface of the liver between the segments. I will go over briefly the segments of the liver as well. So between the segments 4 on the right and segment 3 on the left. And the ligamentum venosum is attached to the inferior surface of the liver between the caudate lobe and the left lateral sector. So liver has the subsegments, and why we divide into segments. So the division of the liver into independent units means that segments can be resected whenever we need for surgical resection without damaging the remaining segments. That's the significance of these segments. As you can see in these diagrams, there are different segments of the liver as well. And basically, it helps to preserve the viability of the liver following the surgery. Surgery sections define the peripheries of each segment. So let's go over pretty quick about the blood supply of the liver. So the blood supply, the liver has a dual blood supply, arterial and the portal. So the liver receives blood supply from two main sources. The first source is the hepatic artery, which delivers the oxygenated blood from general circulation. And the second is the hepatic portal vein, delivering the deoxygenated blood from the small intestine containing the nutrients. So liver has a unique blood supply, unique dual blood supply. And it basically from the proper hepatic artery is about 20 to 30%. And from the portal vein is about 70 to 80%, as you can see in this diagram. So the portal vein basically carries the blood from the digestive system, which removes most of the oxygen in the blood to the liver. And about 70 to 80% of the liver blood supply comes from the portal vein. And the blood has, portal vein blood has nutrients from the digestive system, and the hepatic artery supplies the liver with the oxygen-rich blood from the heart. So the hepatic artery basically arises from the celiac trunk. The celiac trunk comes off the anterior surface of the abdominal aorta at the level of T12 and L1 between the right and the left crura of the diaphragm. And it is a very short structure, it's about 1 centimeter, and that trifurcates into the common hepatic artery, the splenic artery, and the left gastric artery. So celiac trunk gives the 3 branches, and one of these is a common hepatic artery. So the common hepatic artery runs towards the right on the superior border of the proximal body of the pancreas. And after giving off the gastroduodenal artery behind the first part of the duodenum, above the neck of the pancreas, it continues as a proper hepatic artery. And it goes into the free edge of the lesser omentum to the left of the bile duct and in front of the portal vein. So basically in the hepatic hilum, it divides into the Y-shaped manner into the right hepatic artery and the left hepatic artery. And with the right hepatic artery, it ascends up behind the common hepatic duct. And the cystic artery is usually a branch of the right hepatic artery. And this is all about, can you please go on the next diagram, please? So this is how you can see in this diagram as well. And the portal vein, basically, it's formed by the union of the superior mesenteric vein and the splenic vein behind the neck of the pancreas that collects the blood from the gastrointestinal tract. So superior mesenteric vein and inferior mesenteric vein, and that form the spleen and the splenic vein, and it ascends in the HDL, the hepatodural ligament, behind the common bile duct and the proper hepatic artery, and divides in the T-shaped manner into the right and left portal vein branches into the hepatic hilum. So this is how it's all the portal vein blood supply. And the right portal vein divides within the liver parenchyma into the vertical right anterior spectral branch, and then it divides into the segments. I just talked about the liver has segments, divided into segmental 5 and segmental 7 branches, which then further divides into segmental 6 and 7 branches. And the left portal vein runs below the base of the segment 4, to which it gives off the several small branches, and then it enters the liver parenchyma, where it divides into the branches of to other segments as well, into 4, segment 3, and segment 2. So I will talk briefly why liver has a dual blood supply. So basically, liver dual blood supply increase the blood supply to the liver and maintain the normal liver regeneration in patients with compromised portal vein, like when patient has a portal vein compromise in the thrombosis, for example. So the capacity of the liver to regenerate stays there when the patient has a dual blood supply. So normally it's just for general knowledge how we can improve the blood flow to the liver. Basically, it's again our regular physical activity can help improve the blood flow to the liver. It can help, excuse me, change the composition of the bacteria in our body. It decreases the liver inflammation. It changes how our blood vessels dilate. It reduces the fat in our liver and reduces the overall body fat that helps our improve the blood supply, blood flow to the liver. So you can see how important the regular physical activity in our life. So I will go over briefly about the portal triad. What is portal triad? It's basically composed of 3 major tubes. It composed of hepatic artery, is a branch of the bile duct, and the portal vein. So these 3 make the portal triad. And branches of the hepatic artery carry the oxygenated blood to the hepatocytes. And while the branches of the portal vein carry the blood with nutrients from the small intestine. And the bile duct basically carries the bile products away from the hepatocytes to the larger ducts and the gallbladder. So these are all include the portal triad. So there are 3 things: bile duct, portal vein, and hepatic artery. And then the bile duct, hepatic artery, and hepatic portal vein together constitute the portal triad. And this triad runs between the layers of the hepatoduodenal ligament to enter the liver at the porta hepatis. So porta hepatis, the portal triad pass through enter to the liver at the porta hepatis. So let's go over briefly about the histology of the liver. So under histology, as you can see in the previous diagram, can you please go back? Yeah, over here, you can see the portal triad, and these all 3 tubes you can see here. So let's go briefly about, so now a portal, I want to go over the microscopic view of the portal triad. Next diagram, yeah, you can see over here, portal vein, hepatic artery, and the bile duct under the microscopic view. Next diagram, please. So you can see over here the next one, the portal vein, bile duct, and the hepatic artery. So let's go over briefly the histology of the liver. So microscopic view of the liver, you can see in this diagram, the liver lobules made of the microscopic units called the lobules. The liver lobes, sorry. The liver lobes are made of microscopic units called lobules, which are roughly hexagonal in shape. And these lobules comprise of rows of the liver cells called the hepatocytes, which radiate out from the central point. And the basically the microscopic functional unit of the liver is the acinus and the lobule. So what happens, the surface of the liver is covered by the visceral peritoneum called the serosa. And there's the capsule called the glycan capsule underneath. And at the porta hepatis, I showed you in the previous diagram, the glycan capsule travels along the portal tracts, portal triad, carrying the branches of the hepatic artery, portal vein, and the bile ducts into the liver substance. So the sinusoids are basically the large diameter capillaries lined by the endothelial cells between rows of the plates, or you can say cords of hepatocytes. And these sinusoids also contain the Kupffer cells of the reticuloendothelial system, reticuloendothelial system. And each hexagonal lobule has a central portal tract with branches of the hepatic artery, portal vein, and the bile duct. And you can see the bile canicula between the hepatocytes drain into the bile ductules into the portal triad. So basically, the bile ductules then form the several orders of intrahepatic bile ducts, and in an arrangement resembling like a twigs and branches of the tree. Can you please go on the next slide, please? All right, so you can see over here what we talk about, the acinus, lobule, the portal triad, okay? All right, so let's go over briefly the physiology of the liver. So what are the main functions of the liver? So basically, liver has a critical organ. It has in our body, and it is responsible for multiple functions that helps support our metabolism in our body, help with the digestion, help with the detoxification, help with the storage as well of the vitamins. And the main function is the bile production and excretion, and then excretion of the bile, cholesterol, hormones, multiple drugs, then metabolism of fats, proteins, carbohydrates, then activation of the enzymes, then it has a storage function of the glycogen, vitamins, and minerals. And then there's a synthesis of the plasma proteins such as albumin, then synthesis of the clotting factors. So it also has the filtration with the metabolism and detoxification, protein synthesis. So it has a multiple functions. And basically we can say it's a chemical factory performing over multiple chemical functions in our body. And all the blood leaving the stomach and intestine passes through the liver, and liver processes this blood and breaks down and balances and creates the nutrients, and also metabolizes drugs into the forms that are easier to use for our body and excuse me, that are non-toxic. So let's go briefly talk about, so that's all about anatomy, embryology, microscopic features, physiology. So let's go over what are the symptoms of the liver disease that patient may present with. So whenever there's a liver disorder, patient presents with abdominal pain, the common feature, with abdominal swelling, swelling in the legs and ankles. Patient will present with itchy skin, and then patient has a yellowish discoloration of the skin, and the white part of the eyes is called jaundice. So patient can present with the jaundice, patient present with a dark color urine, pale stool, constant tiredness and fatigue, and nausea and vomiting. So these are the common symptoms patient presented with any liver disorders. And before talking about the case studies, let's go over briefly the diagnostics test. So of the liver diseases, whenever there's liver disorders, how we can diagnose. So as I mentioned about the sign and symptoms, so patient, what we do? So we do a bunch of blood tests and use to assess the liver disorders, and these are called the LFTs, or liver function tests. And these tests can be normal at many stages of the liver diseases. But these blood tests can detect if we have low levels of certain substances in our body, such as protein called serum albumin, which is made in the liver. So that is synthetic function of the liver to make the synthesize the albumin. So common liver function tests, we include the ALT, called alanine transaminase, then AST, aspartate transaminase, then alkaline phosphatase, then we check the albumin and total protein level in the blood. We can check the total bilirubin, then direct bilirubin, indirect bilirubin. Then other tests we do the gamma glutamate transferase, also called GGT, then prothrombin time, and then we can check the viral panel as well to check for viral hepatitis. And then there are the imaging modalities as well. Pretty quick, we can do the ultrasound, we can do CT scan, we can do MRI of the liver to assess the liver damage, and then we can do, and we can take the tissue samples by removing the tissue sample. It's called biopsy of the liver, and we can it can help us diagnose the liver disorders. And these are all the modalities we can use to assess the liver disorders. And pretty quick before talking about the case studies about liver disorders, there are the risk factors that can, what are risk factors can increase the liver diseases. It includes moderate and heavy use, alcohol use, obesity, diabetes, mellitus can cause it. Some people use the body piercing and tattoos can cause liver disorders. Shared needles or inject drugs. Blood transfusion before 1992, there was all the risk factors, and contact with other people's blood and body fluids. So, and other risk factors, high cholesterol can cause a liver damage as well. So these disorders may lead to the fatty liver, it can cause the cirrhosis of the liver, it can cause the liver cancer. So these are all the liver conditions. And hepatitis of the liver means a viral infection, can be viral, it can be drug-induced hepatitis. And then when there's a fatty liver disease, when advanced stages, we need a liver transplant. All right, so let's go over our case studies, and let's go over case study number 1. Minahal, can you please go over the first case?
Yes, case study 1. A 28-year-old woman presents with insidious onset of low-grade fever and jaundice for 1 week. Examination shows an enlarged and tender liver. Lab studies show albumin 3.2, ALT 3500, AST also elevated, bilirubin elevated, leukocyte count within normal levels, the HBS and AG positive, IgM positive, HCV antibodies negative, and HAV negative. The question is, which of the following is a potential cause for these symptoms and laboratory results?
Good, very good. So now they're asking about the risk factors. Remember we talked about, right? What can cause? So first of all, we need to know what's going on with the patient. So you can see patient has jaundice, patient has low-grade fever. On examination, patient has enlarged tender liver. So we think something going on with the liver, right? So what are the risk factors? And they also mentioned that hepatitis B, C, IgM is positive. So what's going on? So we can see what are the risk factors. So Minhal, can you tell me, what do you think?
I think that this is possibly a hepatitis
Very
A.
good, very good. Yes. So it's what do you think? Which is viral hepatitis, or what do you think?
It's probably viral hepatitis because the IgM is positive.
Okay, good, very good. Yes. So this is basically viral hepatitis B. So they're asking for the risk factors for hepatitis B. Answers are prior transfusion of blood and blood products. It can be unprotected sexual intercourse. It can be use of IV drugs and working in the hemodialysis center. So these are the risk factors for the hepatitis. And this virus can be found in all body fluids, including blood, semen, saliva, sweat, tears, breast milk, and pathological effusions as well. So thus a variety of routes and clinical settings are associated with the hepatitis B virus transmission. So they are talking about which or how hepatitis B virus can be transmitted. And so these are all the risk factors we talk about. They're the routes of transmission of hepatitis B virus infection. So let's move on to our case study number 2.
Case study 2, a patient presents to a physician with severe jaundice. Physical exam reveals a nodular enlarged liver. In addition to the generalized nodularity of the liver, the physician can feel one nodule that is much larger than the others. CT of the abdomen confirms multinodular cirrhosis and demonstrates a 7 centimeter mass near the lower border of the liver. CT-guided biopsy of this mass shows a malignant tumor derived from hepatic parenchymal cells. Which of the following risk factors is most associated with the development of this tumor? A. Aflatoxic exposure, B. Hemochromatosis, C. Hepatitis B virus infection, D. Opisthorosis infection, or E. Thorotrast exposure.
Good. So they're asking about the patient has, in this scenario, is a hepatocellular carcinoma. So patient has a mass on the CT scan, biopsy showed malignant tumor, right? So patient has a hepatocellular carcinoma, and they're asking what is strongly associated with the development of this tumor. So among all these, the hepatitis B virus infection. So as we talk about the transmission first, now in this case study, we're learning about the hepatitis B virus. It usually develops in setting of the cirrhosis because of variety of damaging it can cause by variety damaging agents. And the most common etiologic factor, both worldwide and the United States, is infection with hepatitis B or hepatitis C. So we don't have hepatitis C option here. So we just have hepatitis B virus infection. So these are the two, hepatitis B virus infection or hepatitis C virus infection are the most common worldwide. And other important risk factors include alcohol abuse, hemochromatosis, and aflatoxin exposure. But most common are the hepatitis B and C. So aflatoxin is basically a fungal toxin found in the contaminated bean products, like including soybeans and soy products. And hemochromatosis basically is a disease of, it's a disorder of the iron metabolism, which particularly damages the liver, it damages the pancreas, heart, and skin as well. And the option D is basically a liver fluke that infects the biliary tract and predisposes for cholangiocarcinoma, not the hepatocellular carcinoma. And the option E is a radiological contrast medium that is no longer used because it predisposed to for the cholangiocarcinoma, not the hepatocellular carcinoma. So we can see the most associated risk factor for the hepatocellular carcinoma is the hepatitis B or hepatitis C infection. All right, so let's move to our next case study.
In the case study 3, a 28-year-old man comes to the emergency department complaining of abdominal pain. He has no significant past medical history, has had no recent illnesses, and denies any alcohol or drug abuse. He reports that 3 days ago, he developed acute pain in his right upper quadrant. The pain was non-radiating and was associated with nausea and 2 episodes of non-bloody, no bilious emesis. He also reports that 2 days ago, he began to turn yellow. On examination, he is afebrile and has scleral icterus with mild jaundice of the skin. His right upper quadrant is tender with no palpable gallbladder and no Murphy's sign. Determination of which of the following is the most appropriate next step in diagnosis.
Good, very good. So now they are asking about what is the next step. So let's go over pretty quick about this case study. The patient presented with the symptoms. It's 11 o'clock. And patient has a yellow discoloration. So what do you think? Is acute symptoms going on? So correct answer is acute infection, hepatitis A IgM titer. So we'll talk about in detail. So, and I will, let's go over pretty quick. So patient likely has an acute hepatitis A infection. And the prodrome of this infection is very similar to the patient presentation, like within 10 to 14 days after infection. And many patients will manifest like varying degrees of abdominal pain, as well as jaundice, that is yellowish discoloration of the skin. And this disease is self-limited and usually transmitted by the contaminated shellfish, and it's the oral anal contact with an infected person or their feces. And it does not predispose patient to the same long-term risk and infection with other hepatitis viruses. And in the acute setting, what happens? In acute setting, serum IgM antibody may be positive. So I will go over pretty quick. Why not serum hepatitis IgG titer? Because it would be seen months after the acute infection. So in acute is IgM, and for long, after months, it will be IgG titer. And serum hepatitis B surface antibody is a marker for the previous hepatitis B exposure. And also the positive C hepatitis C antibody, serum antibody, hepatitis C antibody is not is a marker for the hepatitis C infection. And although both B and C varieties can cause acute viral illnesses, similar to in this case study, but the epidemiology of the transmission is quite different from this patient risk factors. That's why we are not picking up this hepatitis C infection, and both agents are transmitted via the blood-to-blood contact. And the current epidemiology indicates that this is primarily by the IV drug abuse exposure to the infected blood. Like it can be in the healthcare workers and by accidental needle stick, and those are the exposures. And unlike hepatitis A, which has no long-term sequela, and it's, as I mentioned, it's a self-limited disease, and both hepatitis B and C infections are associated with the significant long-term morbidity and mortality. And hepatitis C is the most common cause of the non-alcoholic cirrhosis and liver damage and liver failure. And the positive serum hepatitis C RNA level is a test ordered after initial exposure to hepatitis C and is used to follow the activity of the disease over the time. And unless hepatitis C infection was suspected in the patient, and this test is not appropriate in this case study. So I would like Minahil to go over pretty quick and teach us about, through this diagram, about all these antigen, about these serum levels of these serum titers.
Okay, thank you, Dr. Chima. So basically, you can see here on the y-axis, it's talking about the response to infection of critical illness and acute hepatitis infection. You can see here that as the response increases, you can see the difference in different lab values. For example, ALT spikes at the 4th week. So on the x-axis, you go by weeks after infection. The viremia and the acute phase happens in early stages. So if you're suspecting acute hepatitis, then you would be able to see IgM antibodies or immunoglobulin M antibodies. Or immunoglobulins, excuse me. And then later on, in a few weeks later, when it becomes more chronic, that is when you'll see IgG or immunoglobulin G antibodies after several weeks or months. So that is a differentiation between acute and chronic in terms of in terms of antibody results. IgM is usually associated with acute, and IgG is associated with chronic infection.
Good, very good. So let's move on to our next case study.
Case study 4. A 45-year-old African-American man is taken to the emergency department because he is vomiting fresh blood. His temperature is 37 degrees Celsius, blood pressure is 65 over 30 millimeters of mercury, pulse is 120 per minute, and respirations are 24 per minute. The patient is stabilized, then taken for emergency endoscopy. The source of bleeding is a tortuous vein near the gastrophageal junction. The bleeding is successfully stopped by banding of the vessel. Which of the following is the most likely underlying condition predisposing this patient for this complication? A. Alcoholism. B. alpha-1 antitrypsin deficiency. C. Hemochromatosis. D. Hepatitis A infection. Or E. Hepatitis B infection.
All right, good. So what do you think? So you can see the patient has hypotension, low blood pressure, patient has tachycardia, heart rate is 120, and patient came to the emergency department with these symptoms of vomiting fresh blood.
Could it be alcoholism?
Okay, good. Yes, very good. So this patient has a bleeding esophageal varices. So what is that? So basically, these are the dilated blood vessels that usually develops when a patient has cirrhosis. Because when cirrhosis blocks the blood flow from the portal venous system, as we learned about, there's a dual blood supply, right? Portal vein and hepatic artery. So when there's a blood flow from the portal venous system through the liver and back of the systemic circulation. So what happens is a hypersplenism, there's a AV malformation that markedly increase the blood flow in the portal system. can also cause the esophageal varices. And even in the absence of cirrhosis, it can cause it. And any type of cirrhosis can potentially cause bleeding esophageal varices. And we should be aware that the most common cause is alcoholism. And that is possibly because it is both very common, and the patient may be accompanied by the gastritis as well, which makes it easier for the varices to start to bleed. So alcoholism can cause a gastritis as well. And these varices can be managed by the either sclerotherapy or by the endoscopic banding of the bleeding vessels. And the long-term prognosis remains very poor for these patients because they are often eventually either because of given high morbidity and mortality because of the complication of the advanced cirrhosis. So alpha-1 antitrypsin deficiency is a rare cause of cirrhosis, and also hemochromatosis is a much less common cause than alcoholism as cause of cirrhosis. Hepatitis A infection may cause fulminant hepatic failure, but does not cause the cirrhosis. And hepatitis B infection is also a relatively common cause of cirrhosis, but it is not as strongly linked to the bleeding varices as is the alcoholism. So in real life, a coexisting alcoholism and hepatitis B function are the more common causing the esophageal varices. All right, so let's move over to our next case study.
A 60-year-old woman presents with complaints of chronic fatigue and mild pruritus. She has a history of rheumatoid arthritis and autoimmune thyroiditis. On examination, her liver is modestly enlarged, firm, and non-tender. Skin xanthomas are noted. Routine serum chemistry studies show sodium normal, potassium 5.1, chloride 102, bicarbonate 25, urea nitrogen 25, bilirubin total 1.3, AST 55, ALT 48, albumin 4.1, alkaline phosphatase 240, creatinine 0.8. Follow-up lab studies demonstrate a serum gamma glutamyl transpeptidase level of 150 and a serum cholesterol of 240 milligrams per deciliter. Immunoglobulin studies reveal a marked elevation of serum IgM. Ultrasound demonstrates diffuse enlargement of the liver without marked echogenicity. Endoscopic retrograde cholangiography demonstrates an intact extrahepatic biliary tree accompanied by stricture and loss of ducts within the liver itself. Liver biopsy shows a florid bile duct lesion with patchy inflammation and destruction of septal and interlobular bile ducts. Antibodies directed against which of the following antigens are present in up to 95% of patients with this disease? A. Double-stranded DNA. B. Hepatitis A virus. C. Hepatitis B core antigen. D. Hepatitis C virus. Or E. Mitochondria.
Good. So in this case study, they mentioned about diagnostic test ultrasound, they mentioned about ERCP, they mentioned about, right? So now this is an autoimmune disorder, and they want to know which antibodies are directed, are present. So this is the answer is E, mitochondria. So this disease is called primary biliary cirrhosis. This is an autoimmune disorder. It is characterized by the progressive destruction of the intrahepatic bile ducts. In early stages of the disease, what happens is the intense inflammation of the bile ducts that can be seen on the biopsy, as in our case study, and often accompanied by the bile duct proliferation when liver attempts to compensate. And then the later stages of disease, it is characterized by the initial portal fibrosis that eventually evolves to the cirrhosis. And patients are more likely in the females, is age range between 35 to 70 years of age, and typically present with the insidious onset and often have history of other autoimmune disorder as well. And the symptoms present with the chronic fatigue, pruritus. These are the common initial complaints patient presents with. And on examination, patient has hepatomegaly, means liver enlargement. It can be hepatosplenomegaly, means enlargement of liver and spleen both may be present. And then the baby skin xanthomas is called hyperpigmentation, also present. And in the lab studies, when the blood workup, what happens is the elevation of alkaline phosphatase, elevation, and then the gamma glutamyl transpeptidase as well. And these are the out of proportion to those of the serum bilirubin and aminotransferase. And on the ERCP, the endoscopic retrocholangiography can be helpful in distinguishing the condition from the like primary sclerosing cholangitis, which damages both the extrahepatic and intrahepatic biliary system. So there is a difference between these two conditions. So biopsies in this disease may demonstrate bile duct destruction, and the biopsies are more likely to show us the non-specific hepatic fibrosis or hepatic cirrhosis. And very helpful tests in this measures are autoantibodies directed against mitochondrial antigens. So this autoimmune disorder related to the mitochondria. And since this test is positive up to 95% of the patients with primary biliary cirrhosis, and the few patients with autoimmune chronic active hepatitis may also have these antibodies as well. So other antibodies they talk about anti-double-stranded DNA is quite specific for SLE, for systemic lupus erythematosus. And hepatitis A usually produces acute hepatitis, which is more marked elevation of the transaminases. And then antibodies to hepatitis B core antigen and hepatitis C virus, as we talked about in our previous case studies, is usually used for evaluation of the chronic viral hepatitis, and which microscopically may show like portal inflammation. It can show us the fibrosis, but it does not show the selective damage of the bile ducts. So that's a differentiating point over here. All right, so let's move on to our next case study.
Case study 6, a 34-year-old woman undergoes clinical investigations because of chronic dyspeptic symptoms, such as mild nausea, bloating after meals, and mild right upper abdominal pain. She is otherwise healthy and takes oral contraceptives only. Physical exam and lab studies are normal. Liver ultrasonography reveals a 5-centimeter well-circumscribed mass in the right hepatic lobe. A percutaneous needle biopsy shows a lesion consistent with hepatic adenoma. When symptomatic, which of the following is the most common clinical presentation of this tumor? A, abdominal pain, B, jaundice, C, metastatic disease, D, portal hypertension, E, rupture into peritoneal cavity.
Good. So in this case study, they mentioned the patient has hepatic adenoma. So they want to know specifically with hepatic adenoma, the clinical presentation. As we talked about briefly in the beginning of our session, that patient present with liver disorders, abdominal pain, it can be jaundice, right? So specifically in this hepatic adenoma, the most specifically presentation is rupture into the peritoneal cavity. So what is liver adenoma? Liver adenoma is basically an infrequent benign tumor composed of the hepatocytes arranged with the laminar pattern as the normal hepatic globules, as we saw in the microscopic picture of a liver. And it is usually clinically silent. And it occurs most frequently in association with the oral contraceptives, anabolic steroids can cause this. And when symptomatic, its most common clinical presentation is a rupture into the peritoneal cavity with the consequent hemoperitoneum and shock. So these are the presentation of the patient with hepatic adenoma. And then abdominal pain is a symptom of many hepatobiliary diseases, including hepatitis, carcinoma, cholelithiasis, is a gallbladder stones. And the pain of the hepatic origin is presumed from stretching of the capsule. It occurs in acute hepatitis. And the pain of the biliary region derives from the acute distension of the gallbladder, usually because the gallstones blocking the cystic duct or common bile duct. And jaundice is not a mainstream of liver adenoma. In the hemolytic disorders, it can be in the diffuse hepatocellular damage, and the obstruction of the biliary pathways are the most common conditions resulting in the jaundice. And the metastatic disease is not a consequence of the liver adenoma because it's a benign disease, it's a benign tumor, and the liver adenoma may be extremely similar histologically to the well-differentiated hepatocellular carcinoma, so that one may be mistaken for the other as well. And the portal hypertension may result from the prehepatic causes like thrombosis of the portal vein for any reason. It can be hepatic causes like cirrhosis, or any infiltrative conditions can cause it. And the post-hepatic causes like obstruction of the hepatic veins or right-sided cardiac heart failure, right-sided heart failure can cause it. And the well-demarcated tumors such as liver adenoma, do not lead to the portal hypertension. That's the reason we will rule out these other options. Okay, so answer is in this scenario is a ruptured into the peritoneal cavity. So let's move on to our next case study.
Case study 7. A 45-year-old man undergoes a routine physical examination with screening blood studies. Physical examination is notable for an increased liver diameter. The liver edge is palpable and without irregularities. Blood studies show elevated liver enzymes. The clinician suspects alcoholic hepatitis. Which of the following findings would tend to support this diagnosis? Alanine aminotransferase equals 2000, aspartate aminotransferase or AST over ALT ratio equals 2.5, the GGT equals 20, the MCV 65, or platelet count 600,000.
Good, very good. So in this case study, we're talking about the alcoholic hepatitis. And we're going to talk about how we'll support this diagnosis. So based on these blood tests, I mentioned in the beginning, we do the blood test, right, for any liver disorders. So diagnosis of alcohol in this answer is B. So the diagnosis of alcoholic hepatitis has enough social implications that it is important to be reasonably sure that it is correct before suggesting it. So one of the more helpful rules of thumb in making the diagnosis is that ratio of the serum aspartate. AST to serum ALT is usually greater than 2 in alcoholic hepatitis. And other indices are affected by the alcoholic hepatitis, but are not as specific for this disease. So that's the reason we will pick up the answer B. And very high ALT levels are more correlated with the viral hepatitis. And in alcoholic hepatitis, elevation is around 250 is more typical for the viral hepatitis. And the GGT level provides another helpful clue to the alcoholic hepatitis in that it is often markedly elevated in these patients, and normal levels for males are less than or equal to 65, and for females less than equal to 45. And the MCV is frequently elevated and can be used as a marker for alcoholic hepatitis because it gradually returns to normal with drinking cessation. And choice E is often decreased as a direct toxic effect or secondary to the hypersplenism. So in this, we were learning about the alcoholic hepatitis diagnosis. All right, so let's move on to our next case study.
A 40-year-old woman comes to the physician because of fever and chills, jaundice, and right upper abdominal pain radiating to the shoulder for 24 hours. At present, the patient's temperature is 39 degrees Celsius, blood pressure is 100 over 60 millimeters of mercury, pulse is 110 per minute, and respirations are 20 per minute. She is admitted for further diagnostic evaluation. Serum chemistry studies show ALT 100, AST 80, bilirubin total 4.5, alkaline phosphatase 800, amylase 200, prothrombin time 12 seconds, bilirubin direct 3.5. White blood cell count is 12,000 with 70% neutrophils. Which of the following is the most likely diagnosis? A. Acute cholecystitis, B. Acute hepatitis, C. Acute pancreatitis, D. Cholelithiasis with cholangitis, or E. Cystic duct syndrome.
Good. All right, so in this case study, they talk about it can be gallbladder disease or the liver disease, right? Or pancreatic disease or bile duct disease. So that's we have to figure out what's going on with the patient. What is the most likely diagnosis? So in this case study, they gave us the patient has a fever, patient has a right upper abdominal pain, patient has jaundice. So these three made a Charcot triad, so which is a diagnostic of acute cholangitis. And this usually results from a small gallstone impacted within the common bile duct. So blockage of this answer is D. So cholelithiasis with cholangitis. So blockage of the common bile duct results in the cholestatic jaundice, and it can cause elevated bilirubin level, and then it causes high serum alkaline phosphatase level, and the gram-negative bacteria then penetrate into the biliary ducts and cause the ascending cholangitis. So with what happens when there's ascending cholangitis? It's called fever. It causes neutrophilic leukocytosis, and the pain is due to the acute distension of the gallbladder. And this condition must be urgently treated with cholecystectomy. And other options, acute cholecystitis associated with the gallstones, usually impacted within the cystic duct, and patient has a colicky pain and is usually not associated with a fever, but jaundice can occur in some of the few cases. And this condition must be treated with the cholecystectomy as well. And acute hepatitis manifests with the mild right upper quadrant abdominal pain, with nausea, with anorexia, low-grade fever, serum levels of AST and ALT markedly elevated, that helps to differentiate this condition from the cholangitis. And acute pancreatitis, basically it manifests with the extremely intense epigastric pain. As we talk about the regions, there are different 9 regions, the epigastric region, and this usually radiates pain to the back. Patient has a high serum levels of amylase and lipase that support a diagnosis of the acute pancreatitis. And the mild elevation of amylase may be seen with the cholangitis, and the patient may present with mild jaundice as well with acute pancreatitis. And the option E, the designation of the cystic duct syndrome, is characterized by the dyspeptic symptoms like upper abdominal discomfort, nausea, bloating, flatulence that manifest after having meals, and that is caused by the biliary dysfunction. So these are 2 situations in which cystic duct syndromes may develop, like a patient has a pre-cholecystectomy resulting from obstruction of the cystic duct by the fibrosis or kinking of the duct. And post-cholecystectomy, due to can be because of incorrect diagnosis, because of the neuroma of the cystic duct stump, any foreign body granuloma, and the common bile duct anomalies can cause it. So let's go over, Minahal, can you talk a little bit about this acute cholangitis?
Acute cholangitis, basically it has a triad of 3 symptoms, and if they're fulfilled, then you can suspect in your differential the Charcot's cholangitis triad, which are fever, jaundice, and abdominal pain, specifically in the right upper quadrant. And I also wanted to talk about how basically this tends to be an emergency, right? Like because it is an acute cholecystitis. You can see that that could be caused by the small gallstones leading to the common bile duct blockage. And if you see the cholestatic jaundice, you need to still suspect on your differential the need for a cholecystectomy, right? A gallbladder removal. So I think this is what it looks like. After surgery, you just remove the gallbladder because it's considered an acute emergency.
Good, very good. So it's a acute condition that need to be treated urgently. All right, so let's move on to our next case study.
Case study 9. A 45-year-old woman is taken to the emergency department with severe colicky right upper quadrant pain for the past 2 days. She's on medications and denies alcohol use. Ultrasound studies show gallstones, and the patient is taken for cholecystectomy the next morning. Intraoperatively, it is noted that the liver has a yellowish color, and a liver wedge biopsy is submitted along with the gallbladder to pathology. The pathologist reports steatosis with a predominantly macrovascular pattern in the liver. Which of the following is the most likely explanation for these findings? A. Breast cancer, B. Chronic pancreatitis, C. Diabetes mellitus, D. Peptic ulcer disease, or E. Systemic lupus erythematosus.
Good. So in this case study, they want to know the patient's presentation, what is the explanation, what's causing it. So we can see that patient has a fatty liver, right? Or steatosis, they mentioned that. So we need to know what is the common cause. So common cause of diabetes mellitus, answer is C. So patients, there are a wide variety of causes. And the 3 most common in medicine, in clinical medicine, is in the United States are alcohol use, obesity, and diabetes mellitus. So in this case, diabetes mellitus, and the rare causes include the jejunal bypass surgery, malnutrition can cause it, and such other complications from drugs like glucocorticoids can cause, synthetic estrogens can cause, other medications like imidron and tamoxifen can cause it. So the specific etiology of steatosis cannot be determined by just pathologic examination. So clinical correlation is very important. And the cases may be picked up by incidentally, as in this case, or during liver biopsy performed in patient for other reasons. For example, a patient with asymptomatic patient with a 2 to 3 fold increase in AST level or ALT level, right? And tamoxifen therapy for the breast cancer is an unusual cause of fatty liver, and the chronic pancreatitis does not cause fatty liver, although both can coexist in alcoholic patients and patients who have alcoholic use disorder. And peptic ulcer disease does not cause a fatty liver, and the glucocorticoid therapy in SLE is an unusual cause of the fatty liver. So the answer is diabetes mellitus. So let's move on to our last case study.
Sorry, I was muted. Case study 10. A 50-year-old alcoholic woman is brought to the emergency department 24 hours following a suicide attempt by ingestion of 5 grams acetaminophen and 80 milligrams of diazepam. A patient's neighbor relates that she had been drinking heavily for the past week. The patient is drowsy and difficult to arouse. Her temperature is 36.5 degrees Celsius. Physical exam reveals mild jaundice, fetor hepaticus, and gingival bleeding. Lab studies show AST 2500, ALT 3000, bilirubin total 2.5, and prothrombin time 23 seconds. Which of the following is or are the most important factors leading to this patient's hepatic disease? A. Acetaminophen alone. B. Alcohol alone. C. Alcohol and acetaminophen. D. Diazepam alone. Or E. Diazepam and alcohol.
Good. So in this case study, we are learning about the risk factors. What can cause the most important risk factor causing the hepatic failure, right? You can see the AST, ALT is sky high, right? So what's going on? So this patient has a sign and symptoms of fulminant hepatic failure. So most common cause is both alcohol and acetaminophen. Answer is C. So what happens? Both these drugs, alcohol and acetaminophen, cause the signs and symptoms of fulminant hepatic failure, as we can see in this case study. So infectious hepatitis due to hepatitis B virus is responsible for half of the cases of fulminant hepatitis in the United States. And the fulminant hepatic failure carries about 60% of the mortality rate. And the drugs that are most frequent non-viral cause of fulminant hepatic failure are the acetaminophen, because acetaminophen produces liver injury in a dose-dependent fashion. Like acute acetaminophen overdose usually manifests with doses higher than 7 grams in adults, but concomitant alcohol abuse lowers the threshold of hepatic toxicity. So patients with chronic alcohol abuse, chronic alcohol use disorder may develop the acute diffuse liver necrosis. That is basically the pathological substrate of fulminant hepatic failure after taking as little as about 4 grams acetaminophen within a 24-hour period. And the synthetic effect between the alcohol and acetaminophen, that is a thianol, is mediated by the activating action of alcohol on cytochrome P450. So as we all learn in our biochemistry in undergrad about cytochrome P450 system, right? So these both alcohol and acetaminophen affects the cytochrome P450 system, which converts acetaminophen into the highly toxic intermediate. And this toxic substance depletes the hepatic glutathione stores in our hepatocytes, results in increasing concentration of free radicals, and consequent cause the cellular toxicity, hepatotoxicity. That's all the pathophysiology behind using overdose of acetaminophen and alcohol. And why not option A? So acetaminophen alone is capable of producing significant hepatotoxicity, especially in the children. And the patient's history in this case scenario, in this case study, suggests that alcohol played a contributing role in this case study. And alcohol alone is also a hepatotoxic drug, and in large amounts may cause acute alcoholic hepatitis. But the fulminant hepatic failure exclusively related to alcohol toxicity is very rare. And diazepam alone does not explain the clinical and lab findings of hepatic failure. And diazepam overdose results in the prolonged sedation, usually the resolves with supportive measures. and usually it causes a respiratory depression. Is a more significant presentation and is a potentially life-threatening consequence as well. And this is particularly likely when diazepam or other similar benzodiazepines is ingested in association with alcohol. All right, so these are all our case studies. I hope you learned about different liver disorders briefly from these case studies. And as I mentioned, physical activity can help us with our liver blood flow supply that we can do on a regular basis to keep ourselves healthy. So I will pretty quick go over again self-care. We need our self-care as well. Again, physical health, emotional health, mental health, or spiritual health. And again, for physical health, we need self-care. We need, this acronym, I made it to keep myself, to be used to it itself. S for sleep hygiene, very important. E for exercise on regular basis. L, learn how to manage the stress on daily basis. F for food, for nutritious diet. So please adapt healthy lifestyle in our daily routines to keep ourselves healthy, to keep yourself healthy, so you can achieve your goals. So next, I will talk briefly about how to achieve our goals. We all want to be successful, right? So we all want to be achieve our goals. So what we can do? We have to set rules for us. We have to be disciplined. I would like to share one book with you. The Discipline is Destiny by the Ryan Holiday. It's a very good book. I will recommend whenever you have time, you can read about it. So discipline is basically to have self-management. How we can do that? Basically, we have to do our daily task on daily basis. Whenever, even if we don't want to do it, it determines who we are. It determines what we can do to achieve our goals in our life. Self-discipline is equal to success. Everyone has their own definition of success, right? So some have it, to be successful, to achieve our goals, we have to discipline ourselves. And then most importantly, grit. And for grit, we have to be very passionate about it. We have to be perseverance, persistence, regardless of any obstacles, regardless of any challenges in our life. So keep on moving. And most importantly, I would say our profession and passion should be the same. So whenever we have the same passion and profession is same, we are not working a single day. Because when we are passionate about something, we are passionate about our goals, we are passionate about our profession. So we stay, when we're passionate about something, we're out of time and space. So this is how we can adapt these characteristics in our personality, these specific traits in our personality to achieve our goals, to be successful in our life, right? So what we can do? So by managing ourselves, by disciplining ourselves, we can achieve our goals and then start helping others. Pay back to the community. Start from now as a student life. Small actions, small baby steps. Help your juniors, help your siblings, help your parents, help your friends. Try to pay back as much as you can on the daily basis. So I will stop here and I will wish you all best of luck to achieve your goals. And one day you will start helping others, like one candle lit and another candle. And please try to pay back to the community and know your strengths, work on your weaknesses, and never quit. Whatever you have decided, you want to be in medicine profession, stick to it. You can achieve slow and steady, achieve your goals one day at a time. I'll stop here. Wish you all best of luck. Thank you, everyone.
Thank you so much, Dr. Chima. I really appreciate your time and dedication, and as well as going over all the case studies for us. I know I learned a lot. The link to the TeleShadowing session quiz is now live on teleshadowing.com/certification to receive the certification certificate for today's session. And next week, we'll be having our session on Friday morning, so feel free to tune in. We'll be starting off with Pathology Month, inspired by learning about basically how disease is, what is the root of disease, and overall pathology. So thank you so much, everyone. Looking forward to seeing you next week. Take care. Bye-bye.